Hi, good evening, everyone. Good evening. I apologize because I was having some significant technical difficulties getting on. So I'm so sorry that we're starting late, but glad that I was able to get on and see a few of you all attending. Today we're going to be doing the case list review. And for those who want to participate, you just let me know by raising your hand. I'm going to go through a couple of the housekeeping. I know every week we kind of talk about how you can participate in the webinars. So I just want to make sure that everybody knows exactly how they can participate and get the best out of this next hour. Okay? All right. So this is how you participate. What you'll see is the GoToWebinar control panel. That control panel will give you the functionality and show you the functionality that you need. If that control panel is obstructing your view with any of the slides that I showed tonight, you can open and can close that panel by pressing on that little orange button on the left side, then that's the arrow, okay? And then if you're trying to decide with the audio, which is actually something I had to do today, just know that if you're signed on through the computer, then usually it will default to your computer's mics and the speakers. And you can always go to change to telephone if you're worried about connectivity. That was something I actually had to do tonight. And just make sure, though, that if you switch over to telephone, if you want to participate and you want us to all hear you, make sure you put in that audio pin. So in general, I don't usually use this functionality with putting the questions in the question box. I will look periodically to see if someone did put a question in there, but for the most part, I usually will ask if you want to participate, just raise your hand. It's such a small group of us that it'd be easier if you just raise your hand, and that way I can just unmute you and allow you to ask whatever question that you may have. Or to participate as well, okay? All right, so what we're going to be doing tonight is focusing on the case list review. And I know that there's so many things that are happening right now with regards to AVOG and your test, understanding that, actually just hearing that it will be potentially virtual this year. But still, the manual or the bulletin will still give you an idea of what your examiners are looking for. The examiners, with regards to your case list defense, want to understand how you are taking care of your own patients, okay? This is not a trick. It's just, okay, how when a person shows up either in your office, the labor and delivery suite, your clinic, or you're taking care of them in the ED or in the OR, how are you managing the patients? And there are 4 areas where they kind of focus on, and this is actually in your AVOD bulletin. They want to know that you are developing appropriate diagnoses for a patient when they show up. And in order to do that, they're trying to assess, are you providing or ordering the appropriate laboratory and diagnostic procedures? Are you assessing them clinically? And how do you do that? So whenever a person comes in, they're going to have a chief of complaint. In general, you'll just ask them questions to come up with a differential diagnosis. And then with that differential diagnosis, you'll determine what's the next step, whether it's in your physical exam assessment or the laboratory studies, again, or diagnostic procedures. Now, a lot of times with OBGYNs, because we see some of the same types of patients all the time coming through, we usually say, okay, well, it quacks like a duck, it walks like a duck, it waddles like a duck, it's probably a duck. For example, a 50-year-old patient coming in complaining of hot flashes, a lot of times the first thing we'll default to is, hey, this patient is having perimenopausal or menopausal symptoms, depending on where she is in her stage, and let's go ahead and treat that. With this exam, they need to know how you differentiated that person's vasomotor symptoms with menopause or due to menopause versus a thyroid disorder. So you'll really have to speak to your differential diagnosis and just how you assess the patient. And then the other thing that the board examiners are going to be looking for is, once you have a diagnosis in place, are you coming up with the appropriate treatment for that patient? Counseling them, selecting the appropriate treatment for the patient, whether this is in an urgent, elective, or an emergent situation, all right? And if you remember, as you are, and I don't know if all of you have completed or still working on your case list, there's a section, of course, that says treatments or procedures, pretty much on all three of the case lists. And you have to basically say, this is what I did, whether it's counseling, whether it was an actual procedure, whether it was medical therapy that was given to the patient. And so they're going to be assessing that. A lot of times you can kind of give your examiner an idea of what options that you provide for your patients when you say, I'm counseling this patient regarding their options for, let's say, uterine fibroids. And how I counsel them is with these options. And you can say that even if your treatment is different. That way it at least allows your examiner to say, hey, this physician thought about this treatment, even though it may not have been the best treatment for this patient, but they know that this is a treatment for uterine fibroids, okay? All right. And then the third thing that they're looking for is preventing, recognizing, and managing complications. So it's interesting, as I've been reviewing a lot of your case lists, some of you have been commending the fact that you went through a whole year and didn't have a lot of complications on either your GYN list or your OB list. That being said, there's still an understanding by ABOG that you should be able to manage it if it arises, or at least recognize someone has a significant risk for a particular complication and you know how to prevent it. So just make sure that even if you don't have complications on your list, that you start thinking about, okay, but if this complication shows up, how can I prevent it? And then lastly, this has to do with how do you plan and direct follow-up and continuum of care. And this is with all of your case lists, but you really see it the most when you are doing your clinical or your office case list, especially like if a person comes in with abnormal pap smear, pregnancy patients that require continued care. Let's say a person with smoking cessation and they have to come up with follow-up care, you arrange for follow-up. So you'll need to speak to that and even show a bit of that on your case list as you're actually preparing for your submission of your case list. All right? Okay. So what we're going to do now is, if anybody, I see that we don't have any case lists that have been submitted just yet for review or for people to go over. But if you have a case that you're looking at right now as you are preparing your case list, and you're really kind of concerned about how you're going to defend it, or you kind of want to talk through it, or even kind of get an idea of, maybe do you have the correct wording on your case list, go ahead and raise your hand. I'll go ahead and unmute you if you want to talk about one. And as you think about it, I do have a couple of examples of some case lists I'm going to pull up and kind of talk through. If you want to participate or by using some of the other case lists that I have right now and kind of practicing, that's a great way to do, just kind of get your feet wet. So what I'm going to do for just 1 second, I'm going to stop sharing my screen, because what I would like to do is pull up some examples of the case list. And give me a second while I'm doing that. All right. And I'm going to open this up. All right. And then I'm going to go back to sharing my screen. So for right now, what I will do is ask, I'm almost certain that you can see the screen. What I'm going to do is, if you can't see the screen, just let me know in the question box. I'm assuming that everybody can see it, right? All right. Let me reduce my board. Okay. All right. So this is just an example of a office case list. These are just some cases that I just pulled up. I just kind of want to kind of talk to them. And I'm going to start off with case number 7. First of all, I just kind of want to go over the categories of how everything should be placed on your case list. You may already know it, so I'm just going to go over it very briefly. I just want to make sure that we're all on the same page with just the construction of the cases itself. So for number 7, you'll see in the first category, obviously, this is going to be the person's age, and then their gestation, their G's and P's, gravity and para, right? And then the next is the problem section, and that has to do with why they actually showed up. For number 7, this is a person that came for preconception counseling. And then you'll see with this particular, the person, when they compiled their case list, on the next, they talked about in the diagnostic procedure that a history and physical was done. Now, I know that when people are putting their case list, especially office, they kind of hesitate to always put history and physical. But really, when you have a patient that you're seeing in your office, you are always doing a history and physical. It may depend on whether it's comprehensive or whether it's focal, but you're always doing a history and a physical examination on the patient. And that will include telemedicine. So I know some of you all may be saying, well, I definitely do a history, because I'm going to ask questions, get at least a history of present illness on the patient, and any pertinent like medical, family medical history, personal medical history, so on and so forth. But physical examination, and the answer is yes, you're doing a physical exam, because basically that's the objective part of your assessment of the patient. And that can include whether they're alert and oriented, whether they are fatigued, whether they're lethargic. Obviously, if they're in the office, you're going to see vital signs on the patient. If you saw them walk into the office, you're looking at gait. Neurological function is sometimes what you're looking at. It's not always just the heart, lung, and pelvic exam, okay? So it is fine if you put focused history and physical on pretty much all of your office cases. Now, this particular person put age-appropriate screening test because that was just a high level of how they talked about lab studies, and that's completely fine to do. STD testing, serology testing, genetic carrier screening is what was a part of their diagnostic part, or their, I should say, their workup. And then in the next is just the treatment, the preconceptional counseling, influenza vaccine, prenatal labs, and then they have ongoing care. So what is your examiner looking at? As a person who does mock orals, when I look at this, number 7, first thing I see is the problem. So I have inside my head, what is this physician's way or this candidate's way of approaching preconceptional counseling? What do they discuss? What are they assessing? And when you're looking at the history and physical examination, are you assessing whether that person has comorbid issues that need to be either controlled or optimized to decrease their chances of any type of complication during pregnancy? Are you seeing if there's any family history or prior obstetrical history that could have a negative or adverse effect on their getting pregnant? You're also assessing, obviously, for their ability to get pregnant, checking through their history, both with them and their partner, if they're married, and then, or in a relationship where they're going to not go through infertility, so there's infertility doc. They also asking, are they up to date with vaccinations, and do they have any alcohol use or drug abuse? Are they having any issues with, medications where they're not taking them regularly, like let's say if the person who has chronic hypertension, are we going to have issues with that? And are the medications contraindicated in pregnancy? So those are some basic things that you kind of will think about, just a general picture of the person. And then, of course, in a preconceptual counseling, are you discussing some risk areas that they need to avoid? Cat litter and radiation and medications that they're contraindicated if they do get pregnant. Are they having vitamins and iron supplementation like the prenatal vitamins? So as you are preparing for your exam, those are the things that you need to think about. Now, honestly, I believe that this is what you already do every day, okay? And in some cases, your office may be set up in a way that you have a nurse or a nurse practitioner who's doing some portions of the preconceptual counseling, or at least getting a part of their, the medical history and the full history of the patient, and then you finishing up with the counseling piece. Either way, there's be an expectation that you're able to speak to that when you're actually doing your exam. Okay. All right. So let me go to number 8. And number 8, I'm going to do it a little differently. And what I'm going to do is I'm going to kind of play the role of an examiner so that you just kind of would understand the questions without any type of other feedback. And you can see number 8, you see exactly what the person has. And the question may start off with, all right, I see you have a 20-year-old T1P0 that came in early pregnancy for a visit with you, and you saw her for 3 visits. And I noticed that there's a class 3 obesity. Tell me about what is the effects of obesity in pregnancy, what risks are associated with obesity in pregnancy. So for you as a candidate, first of all, you'll kind of think about, what are all of the risks that are associated with being pregnant and being obese, and how could it affect the pregnancy? Not just during the prenatal period, but also when the person goes into labor. Is there any issues with, risk for shoulder dystocia? Are there any risks for diabetes, pre-gestational diabetes? Are there risks for hypertensive disorder? Are there risks for anesthesia complications if the person has to have anesthesia, depending on, the type of obesity the patient has? And then as an examiner, I can look and say, okay, you have a class 3 obese patient. What are the different classifications of obesity? How are they defined? So this, of course, is just kind of like a very, you either know it or you don't kind of question that your examiner could ask you. And basically, you would start off with the class 1 being at a BMI of 30 to 34.9. And then you could go on in class 2, it'd be 35 to 35.9, so on and so forth. They may even ask you basic things of how do you even calculate BMI in a non-pregnant versus a pregnant woman. And now, these may sound like simple questions. They really are, because, again, they're just trying to get a sense of what you do and how you provide care, how you assess patients. So for this particular patient, there's nothing really that stands out for this patient. So I may, as an examiner, ask about the diabetes screening. And as a candidate, it would be important for you to know, okay, how do I screen for diabetes in pregnancy in my office? What guidelines am I using? If you're just doing the 1 hour, what values are considered abnormal for the 1 hour or the 3-hour glucola? And then if you have somebody who comes back that's positive or screening positive for just gestational diabetes, what is your next step in counseling them about their diagnoses? When you're dealing with office cases, I'm going to let you know that it's really important to not just talk about the medical therapy or procedural therapy. Now, granted, that is important, but also your counseling piece, because that is a part of the treatment. If you're doing any treatment on behavioral modification, nutritional modifications, especially your dietary modifications, encouraging exercise for patients who are like this case in number 8, and making sure you're able to speak to that is very good. Now, somebody may be listening at this point and say, hey, I actually don't do the counseling for my patients who are diabetic. I send it out. I don't necessarily do any of the counseling regarding even medical therapy or insulin therapy once I write the prescription. So that's fine. It's okay to say, these patients are referred to a nutritionist, as you can see in number 8, it says that. But when you're taking the boards, it's also important for you to be able to speak on a high level of, what's going to happen for that patient when they're sent away. All right. No, I wouldn't expect you to know everything that a nutritionist is going to say, but you should have some basics of how you would counsel a patient who has a new diagnosis of gestational diabetes, how you would counsel them on changes in their diet. Okay. So just make sure that you are thinking about that as you're preparing for your exam. All right, so I'm going to come off of Office for a little bit because I want to make sure that I give you examples for both, for all 3 cases. And let me go ahead and pull the next case. That being said, if you want to go ahead, if you want me to review any cases that you currently have, let me know and I can do that. And let me check to see if we have any hands up or questions. And you're a quiet group. All right, let's see, I'm pulling up the next case list. Okay, so this is going to be GYN. And I'm going to go ahead and unmute Dr. Pamela. Hey, Dr. Pamela, before I start rambling, I want to make sure that if you had a question you want to participate, let me know. You are unmuted.
Hey, can you hear me?
I hear you really well. How are you?
Good. I was struggling with the words to use for laparoscopic sterilization when I did like a bilateral salpingectomy.
Hold on one second. I have my computer speaker on. Okay, go ahead. I'm sorry.
I usually label it like a partial salpingectomy in case I'm worried that it won't get covered. So then it just sounded really long the way it was. Does that really matter?
So I just want to make sure I understand. So you're saying that this is for your GYN list, right?
Mm-hmm.
And you're saying that you're doing sterilization and you're doing bilateral salpingectomy?
So I labeled it laparoscopic tubal ligation with bilateral partial salpingectomy.
So you're not doing, are you doing a partial salpingectomy?
Well, I take the fimbria in most of the tube, but you leave a little nub at the cornua, and there's always risk that it won't get covered if you're doing salpingectomies for sterilization.
Ooh, yeah.
So it just sounds really like long, and I didn't know if there's a certain way that we're supposed to label that.
Yeah. So let me ask you differently. What do you put on your post-op diagnosis when you're doing your actual op report?
I'll either do bilateral salpingectomy if it's a private insurance patient versus partial salpingectomy if I'm concerned about coverage.
Okay, but you're actually doing the same procedure regardless?
Yeah, and it's laparoscopic.
Yeah.
If I just do bilateral tubal ligation, it doesn't really indicate on this test if it's laparoscopic or not that it matters, but.
Gotcha. So yeah, that's a great question. What I would say is, for the sake of the board, I would really label what you actually did. And they do have the option of auditing your cases. So if your case post-op diagnosis says one thing, then you may want to put that same thing. To be honest, I think you'll be safe just putting bilateral salpingectomy on it. One way you can label is as two separate things. You can say operative laparoscopy, and then the next line you can put bilateral salpingectomy. If you are worried about wording, but usually that's not an issue. Those are not considered a lot of words.
Okay.
I would, and I can pull it up now, there is a list of abbreviations that are approved by ABOG, and I think BS is approved, actually. So does that answer your question?
Yeah. So just staying true to what you wrote on your operative report is probably the best, is what it sounds like. Rather than
I think it's, yeah, well, even more so, it's true to what you actually did. Because even if your op report says something different, the pathology report is going to probably say that you took out the whole tooth, up to what you could, obviously. Does that make sense? Yeah. I wouldn't worry about saying too much, though. And I'm trying to see if I have a case list that have, honestly, most of them say laparoscopic bilateral salpingectomy, and then that's it. And it sounds like that's what you're doing. So I would definitely just put what you're actually doing.
Thank you.
All right. Okay, no problem. All right. So I'm going to see really quickly if I can pull up that bulletin. I don't know if you all have had the opportunity to take a look at the bulletin, but it's extraordinarily helpful. I tell people that this is what you should use at all times as your quote-unquote Bible as you prepare for your exam. Dr. Chioma, I see your hand is up, so let me go ahead and unmute you while I'm pulling up this bulletin. All right, and you are unmuted, so whenever you're ready.
Hey, good evening. I had a question.
Good evening.
I apologize to backtrack to the office practice
You're
section
okay.
at this moment. I've had a couple of people look at my list, and I've had some conflicting things, so I just wanted to get your take on it. So for the problem, that's clear what to put there, and then diagnostic procedures, as well as treatment. But for results, I've gotten some conflicting things. So for example, I've put the results as the results of the diagnostic procedures performed. So for example, if a pap smear is performed, the results of the pap smear would then go in the results column. But then I've had some people say that the diagnostic procedures column should include the procedure as well as the results. And then the results column is almost for the results of the treatment that you did.
Correct. So I have seen both of those. Historically, what we see the most with cases that are submitted by ABOG and they're accepted are the latter, where you actually put the lab study under the diagnostic procedure. And then if there is a pertinent lab that you wanted to speak to, then you would put the results there. So let's say I put STD panel dash positive chlamydia, right? And then in the results, it would be resolution of symptoms or resolution of infection. That's what we see, I would say, 90% of the time for cases that have been submitted and accepted. That being said, you can do it however you want to do it. It's just if you decide to do one of your cases where you put the results of your lab in the results section, then you would need to do your entire case list like that. It is a little difficult for the examiner to kind of breeze through it because basically they're looking at two things. They're looking at one column to see what labs you ordered, and then they're having to go to another column to see if there were any abnormal findings in the labs or in the diagnostic procedure. That's usually why everybody will put, any significant results in that diagnostic part. Another thing is for that results column, sometimes if you send the patient out, let's say for referral for a psychiatrist or referral for gynecologist, then that also will give you the opportunity to talk about the results of the ongoing, whatever treatment, or if they had to go to surgery or if they had a mass that was operated on a particular different specialist, obviously not you. Then you can put, endometrioid CA or something like that, getting chemo, something like that. But what you were saying before, where the results within that diagnostic section, that's what we see most of the time.
Thank you.
You are welcome. So a couple of things, and I'm going to go back to Dr. Chioma, what you were saying, or the question you were asking. You don't necessarily have to put all the results, and I meant to say this too. You don't have to put all of the results. If you order a CMP, a CBC, I don't know, thyroid panel, the whole nine, and everything comes back normal, it's completely fine to put lab studies and then put, normal, if you put anything at all. But always put, the pertinent abnormal values. Okay, I am going to show my screen again because this right here, I think is really important for you all to know and look at. And this is the acceptable case list abbreviation. And this will go back to a previous question. It looks like BSO, bilateral salpingate oophorectomy, is really the only one. AVOG is pretty particular as to what abbreviations they do accept. Believe it or not, some years they'd have actually changed. If you don't see on this list, and I'm just kind of scrolling through it, if you don't see an abbreviation that you currently have in your case list, if it's not in the approved abbreviation, then I would write it out. That's the safest thing to do. They have quite a few of the popular abbreviations that we use, but make sure that you look at this again before you add any of your abbreviations, okay? All right, and I'm going to scroll all the way to the top so you all know. This is the ABOG bulletin, and you can find it on abog.com. Where is the again? Yep, I just have to give credit where credit is due. All right, so this is the ABOG 2002 Specialty Certifying Exam Bulletin. Okay, I'm going to stop sharing my screen, and I'll see if there are any other questions before I go to another case. And also, if you want to, I can pull up the case. If you want to kind of take a shot at defending a case, we can talk through it. Let me share this one. All right, and you should be able to see a new case list. And I'll give, does anybody, you can just raise your hand. Does anybody want to take a shot at one of these? And I'll talk you through it. All right, I'm going to go through a couple of them myself, and I'll start off here with, let me see, case number, we'll just start off with case number 30. First thing I'm going to talk about is how this is constructed with case number 30. So for this particular case, you have a 30-year-old G2P1 that came in with complaints of abnormal uterine bleeding. All right. 1 second. All right, I think I lost my screen. Give me 1 second. All right, I did visit. Okay, so hopefully you all are able to see this. All right. So basically, I have the patient who has a 30-year-old G2P1 with abnormal uterine bleeding, and it looks like they had older terminology, but complex endometrial hyperplasia without atypia. Note that sometimes now we're using more of EIN, endometrial intraepithelial neoplasia. They also have class 3 obesity, which looks like it's defined here. And then the treatment was a DNC hysteroscopic procedure and luminogestial IUD placement. Some of the types of questions that can come out of here, we'll first start off with the pre-op diagnosis piece. And that's with a person with abnormal uterine bleeding, what are the signs and symptoms of abnormal uterine bleeding, all right? And hold on, give me 1 second because I'm trying to figure out why. 1 second. Okay, it looks like I have already kicked myself out of the meeting, so I'm going to see if I can pull back up my dashboard. Hopefully you all are able to see. Let me see. Hold on 1 second. All right. Well, I'm going to go ahead and finish this one, and then I'm going to probably try to restart the meeting so that I can get back in. So for number 30, and I'm assuming that you can still see my screen. Abnormal uterine bleeding, a patient with abnormal uterine bleeding, the question will be, number one, what are the different causes of abnormal uterine bleeding? This is a good time where you can consider using the Palm-Cohen to kind of talk about the different types of structural and non-structural causes of abnormal uterine bleeding. And then the next question is, so how did you go about evaluating this patient's abnormal uterine bleeding and determining if the patient required surgical therapy? And the best thing to do is just kind of speak to just your basic high-level discussion of your pre-op workup on the patient. Obviously, if there's any type of failed therapy, medical therapy, this is a good time to speak to that. If this is, for this case, you're just getting endometrial sampling and maybe the patient could not tolerate the endometrial sampling or endometrial biopsy in the office, you could speak to that. Or if you got an endometrial biopsy like this one that's abnormal and you want to do more of endometrial sampling and at the same time give some treatment to the abnormal uterine bleeding, then you could speak to that as well. So in the treatment section, some of the questions about hysteroscopic procedures is, what solutions are you using? What medium are you using in order to inflate the uterus in order to see how are you managing the fluids? How would you manage a uterine perforation for a patient that had active bleeding after the perforation or one that did not have active bleeding? At what point would you do a diagnostic laparoscopy on the patient or just keep them in the hospital for a observation? If you're worried about fluid overload, what are the risks or concerns that you would have with the patient? What labs would you order? Those are just some of the basics. Now, that being said, notice that in this case, there were no complications. And if you remember, I was saying at the beginning, the AVOC wants to make sure that you know how to manage complications, right? And even if you don't have that specific complication on your case list, then it's important to actually start thinking about it. So with hysteroscopic procedures, thinking about perforation and thinking about fluid management is important for those patients. And then also pain management. And of course, if a person is having any comorbid issues, what could potentially happen intraoperatively or even postoperatively that could affect the patient. Okay, so those are just some of the basics to think about when you're actually preparing your case list and also preparing to defend your cases. All right, so what I'm going to do is I'm going to see if there is a different way for me to get into the actual meeting, and if not, I'm going to stop it briefly, and then I'm just going to have you all come back in. Give me one quick second. Oh, no, I don't have to do any of that. I found my control panel. Wow, that was special. Okay. All right. Now, do any of you all have questions at all about that particular, how they manage, how they would ask you questions about the hysteroscopic procedures? There was a question earlier about laparoscopic procedures, just how you would write it, but I'm just going to use that laparoscopic bilateral salpingectomy as also a possible question. Let's say that the first case is not a hysteroscopic procedure. Let's say it is abnormal uterine bleeding and chronic pelvic pain, and you're doing a laparoscopic procedure. What kind of questions could come from there? Some of those questions could include what was your multidisciplinary approach with chronic pelvic pain? Now, let me say this. As you're right now still coming up with ways to construct your case list, consider adding some of this language to your case list if you think that this is germane for you and your case list. If it's chronic pelvic pain, your examiner wants to make sure that you did a multidisciplinary approach. You didn't just assume that it was a GYN issue. So did you get a gastro or GI consult? Did you get a urology consult? Did the person get sent to psych? Now, I know that you're probably thinking, wait, I have chronic pelvic pain patients that I didn't send all of them to all of those specialists. And you don't necessarily have to. If you get a really good comprehensive history on the patient, you can determine if they need to see a specialist, okay? But just know that being able to speak to that multidisciplinary approach for chronic pelvic pain is important. Also, the other thing for chronic pelvic pain is having a good differential diagnosis for the patient to show your examiner that you thought of more than just one or two things that could be causing the pelvic pain, especially if you have a patient where you do definitive therapy for chronic pelvic pain. Any patient with a hysterectomy that had chronic pelvic pain, especially if they have benign pathology, you want to make sure that you did everything you possibly could in evaluating them, and also continue providing any type of conservative medical or non-invasive treatment. For laparoscopic questions, other things is they'll ask you, what criteria do you use to determine how a procedure is going to be done? Why are you choosing to do it laparoscopically? Why not do a laparotomy on the patient? And then, are you doing open laparoscopic procedures? Are you doing closed laparoscopic procedures? A question that I tend to ask a lot about is, are these procedures that you do? Let me say it differently. What is the best way that you access the intra-abdominal cavity? That's just a way that I use to determine if you're doing an open or a closed laparoscopic procedure. When you're doing any defense on your surgical cases, anatomy is really important, especially with laparoscopic procedures and putting in secondary ports, and management of if you have any vessel injury. So specifically the inferior epigastric artery. What do you do to prevent injury to the inferior epigastric arteries? And if there is injury, how would you manage it? So those are some basic questions that could come up. And then if you're using the open technique or Hassan's technique, being able to describe that as well. Another thing, this has to do with just the construction of your case list, In the treatment section for GYN, although there may be counseling that you do for these patients, especially if it's a patient that had a permanent sterilization, that would still be part of the pre-op section. So anything you do preoperatively before the patient actually goes into the room, you make sure that you put it in the correct category. All right, so I'm going to switch over. I'm going to stop sharing my screen for a second, and I'm going to, or pause it rather, and I'm going to show you another example. And this example, actually, I'm going to use this as an example to show you how to construct your cases a little differently, and also how to defend them. All right, so for 45, you already see chronic pelvic pain. We've already kind of talked about chronic pelvic pain, right? And how to prepare for those questions. You want your case list to be concise. Why do I say that? Your examiner is only going to have a few moments to glance at your case list. You want them to have a really good understanding of how you're managing your patient. If there's a lot of prose, or you're trying to write out a story, it's really difficult for a person who only has a short period of time to figure out how you manage the case. So then you're at a risk of your examiner saying, you know what, I can't really tell what's going on. Let me just, I see that they have a hysterectomy. Let me make up my own story and ask them questions. This is your case list defense. You want to talk about your patients, because those are the ones that you're going to be studying about your patients between now and November, December, or January. So making your list as concise as possible is important. For number 45, chronic pelvic pain, putting that is fine. Confirmed endometriosis is fine as well. Anything that has to do with the imaging, that's significant. Okay, so the fact that right here it says an ultrasound that says 7-centimeter uterus, MRI that says a 9-centimeter uterus, is not necessarily something that you have to put on there. You can put endometriosis. Imaging suggestive of adenomyosis. Putting that the person has a history of a permanent sterilization is fine, and definitely failed medical management. And making sure that they're all like on one individual line, so you can adjust the font so that, like, for example, you see how failed medical management takes up 2 lines? You can adjust the font so that it's just 1 line. It makes it so much easier for them to look at it. And then, of course, for a laparoscopic procedure, you can just put TLH, since that's an approved abbreviation, but you would have to write out bilateral oophorectomy since the patient already had a salpingectomy, okay? So I hope that helps you a little bit with understanding how to write these. Note that, and I'm going to go back to this one, anytime I see, and your examiner probably saying, see patients like this, that, like abnormal uterine bleeding, then other questions that pop up in my head that say, okay, you have abnormal uterine bleeding. Does this person also have anemia? Is this person on iron therapy? Does this person have abnormal uterine bleeding that's refractory to medical therapy, that's giving them persistent symptomatic anemia? So consider adding that information as possible, if possible. If you look right here at this case, number 70, person that's age 70, I see that postmenopausal bleeding is the main preoperative issue. But at the same time, I see it's a 70-year-old that has absolutely no comorbid issues, which is relatively rare. So if the person is 70, you have an older patient that's, on your list, or even a young patient, and they have hypertension, or they have diabetes, or they had, factor 5, any of those things that you had to optimize. Those are good things to put on your list. You don't want to avoid talking to your examiner. You want to talk to them. You just want to set up your case list in a way that you can lead your discussion. You want to set up your case list in a way that it can catch the eye of your examiner, because you're going to be prepared when it is time to talk about your cases. Another thing that I would suggest as far as patients with hysteroscopic procedures, some have, I've actually seen some that put counseling regarding short and long-term effects of a hysterectomy, specifically on a younger patient. So this is a 45-year-old patient. But if you have any 30-year-olds, then that can be something on there. And obviously you would put whether they had failed medical management or failed, conservative management as well. Okay. All right. Let me see if you all have any questions, because we only have about 7 more minutes left in this time. And I want to give you all the opportunity to ask any questions. It can be related to caseless defense, and it can also be related to your cases. If you're concerned about defense of a case, or even just the construction of your case list, you can feel free to ask. That being said, I know this is early and it's July, and it's hard to think about, oh my goodness, I'm going to have to talk to actually, become board certified. One of the best things to do is to really start practicing now. One of the biggest mistakes that people make is that they say, I'm going to practice, but they practice in their head. Believe it or not, practicing in your head is not quite as beneficial as practicing out loud. I don't know if you've ever, maybe had a disagreement with someone, or you wanted to bring up a really great point, and you came up with this great way of saying it in your head, but then when it was time for you to say it out loud, it didn't seem to go in the way that you planned. That's what happens sometimes with the boards if you don't practice. So make sure that you are able to speak out loud to it. All right, so I want to go over, before we end, an OB case. So if you have any patients on your list, and there's a whole section on your OB, whole category on your OB case list for repeat cesarean sections. If you have cases in that category or any repeat cesareans anywhere in your case list, this is something to consider. You see right here where it has antepartum complications. For this particular patient, it has spontaneous rupture of membrane, prior cesarean. And then for the next case, it has the person who is gestational diabetic and a prior cesarean as well. One thing that you may want to consider is showing that you counseled the patient on a trial of labor after cesarean section, okay? And the reason why is, it's just important that your examiner knows that you're giving that opportunity to their patients, or at least letting them know that that is an option if they fit the criteria, okay? Now, some may say, well, we don't do VBACs at our hospital, so that's not necessarily something that I talk about regularly. Well, it is important that you're able to speak to that and know that that is an option, because even if you're currently at a hospital that doesn't do VBACs for whatever reason, you may go to a hospital that does. And there will be an expectation that you'll be able to speak to, trial of labors and how to counsel them and how to determine if someone actually meets the criteria to do a trial of labor after cesarean. One way also to write it in your case list is by saying desires under antepartum complication or treatment, desires trial of labor or a TOLAC, declined the TOLAC if the person goes for a repeat cesarean. A trial of labor is contraindicated for whatever reason. Those are just ways to kind of say to your examiner, okay, I did talk about it. I did think about it. And that is not necessarily, the best or optimal treatment for the person. There are some people that have put in their cases on the treatment section counseling regarding delivery options. That's just a high level statement that you can put for people with previous cesarean deliveries. You can put that for malpresentations if you have a breech presentation. Counseling the person on their option for delivery would include a discussion about external cephalic version or just going for cesarean. So, that's just an option of if as you're planning out your case list and still constructing your case list. That being said, for this particular case, you have, and I'm going to look at the 32-year-old G2P1 who has late-term pregnancy. Counseling your patients, making sure that they know the indications and contraindications of child labor. They know, what the maternal risks are, what the fetal risks are, whether they have VBAC or whether they are a primary cesarean delivery or a repeat cesarean delivery, what those risks are, and how they will be managed. It's just some basic questions, how you would monitor for pain management, monitor for uterine rupture for a patient who's doing a trial of labor. Just basic things that, like I said, you already do these, so you already know. I do kind of want to mention this really quickly before I close out, is as you're constructing your case list, don't forget some of the other potential complications that you really don't see as complications in OB. So like for both of these patients, one is 39 years old. Remember their advanced maternal age. And remember, if they're advanced maternal age, what treatment did you provide? Genetic counseling, genetic testing. Do they have anemia? What treatment? Iron infusions, oral therapy. Are they smokers? So did you do smoking cessation? Are they adolescent? Pregnancy? So did you get social work consults? For this one, they're gestational diabetic. So did you do control their diabetes with diet or medical therapy for glycemic control? I wanted to show this example to show you that this is what you don't want to do. You always want to make sure that your complication section, anything in here, you have a treatment in the treatment section. So make sure they match. I always say A needs to equal B, okay? All right, so we have actually coming to the end of the hour, and I'm going to give you the opportunity if you have any questions about anything that I said, you need to clarify anything that I said. This is definitely the time to do it. Now let's see if we have any questions. I do have to say I thank you with all of the IT issues that I had tonight. I thank you for your patience with it. And I want to remind you that Exam Pro has a case list review manual, okay? And that if you don't already have it, make sure you get it. If you have it and you haven't already looked at it, take a look at it, because even as you're constructing your case list, this gives you an eye into what the examiner wants, and you can consider putting some of those items on your case list in a concise manner, bullet, only, so that your case list looks complete. But it has the most commonly asked case list questions. It's a very small book, but it's packed with a lot of great information. And it may even trigger, oh, I didn't think about putting that information on there, like a STI, person with STD, coming in and, with contraception, coming in and talking about how you counsel them regarding safe sex practices. Just basic things, okay? I just want to make sure that you have everything that you need on your case list and that you are prepared to defend your cases when it's time in November, December, and January. All right, and if there are no other questions, I am going to go ahead and let you all go. And I wish you all the best of luck on your exam. Thanks.